Medical Center, Dr. John Barker. We have holistic fertility practitioner and clinical director, Ms. Charlotte Byrne, and we have general practitioner, Dr. Azizi Popo Hippolyte. Before we get into it, we will have some opening remarks from our president, Ms. Robin Fravrier, who is not on with us because she's in another time zone that doesn't allow her to be here live. But she has sent us something to give her regards for our webinar this afternoon.
Good afternoon, everyone. I'm Robin Favory, president of Iyanola Wombmanhood. The organization strongly advocates and uses awareness for women with reproductive health illnesses, specifically endometriosis, adenomyosis, fibroids, and PCOS. The month of September is observed globally as PCOS Awareness Month. And so today's session, From Hormones to Health, Exploring PCOS-Linked Conditions, is intended to present you with a detailed overview of how Polycystic Ovarian Syndrome affects the body in various ways. So, PCOS is a common yet often undiagnosed endocrine disorder affecting 1 in every 10 women. However, recent studies have revealed an increased prevalence, indicating that 1 in every 9 women has the illness. As a result, it calls for increased advocacy and understanding, as well as a more proactive and holistic approach to treating PCOS symptoms. This afternoon, we are pleased to have our esteemed panelists who will deliver factual and impactful information during their presentations. Dr. John Barker, consultant, OBGYN, and medical director of GRB Medical Center, Dr. Azizi Popo Hippolyte, general medical practitioner, Ms. Brenda Roach, counseling psychologist and mental health advocate, and Ms. Roach has worked closely with our organization over the years. Ms. Charlotte Byrne, holistic fertility practitioner and director of the Natural Fertility Center in St. Lucia. Ms. Charlotte has been instrumental in providing support to women in St. Lucia in terms of managing their symptoms and also improving their fertility. Today, we'll break down the common symptoms from irregular periods, excess hair growth, and acne to potential weight gain, and discuss the critical link between PCOS and infertility, mental health effects, sleep conditions, and endometrial cancer. I invite you to take this opportunity to take notes, ask questions, and engage with our panelists. Though I'm unable to attend this session, I wish you all a productive and invigorating discussion and extend my gratitude to all participants, team members of Iyanola Wombmanhood, and stakeholders who have made this event possible. Thank you.
Yes, and thank you to Robin for these great remarks, reminding us of the very interesting and cross-sectional discussion we will have this afternoon. So I just want to say hello to everybody who's in the chat again, everybody who's joined us this afternoon. We have Kira from Miku, Rena, St. Lucia. We have Joanne from St. Vincent, Michelle from St. Lucia, Carla from Mondudor, Zena, Entrepot, Yasmin from Sarat. We have Sharon from Barbados. Sharon DL, sorry, from Barbados. We have Vig Antoine from Viewforts, and Jennifer Popo from St. Lucia, and Yulene from Moshi, St. Lucia. So thank you everyone for joining. And now I will move on to introducing our panelists. Our panelists, like we say, are very experienced in their field. They have such great knowledge that they want to impact on us this afternoon. So first we have Ms. Brenda Roach. And Miss Brenda Roach is a registered counseling psychologist who specializes in helping her clients overcome grief and loss. This includes death of a loved one, loss of a relationship due to illness or breakup, loss of financial security, loss of self, or disenfranchised losses, such as a miscarriage or being unable to conceive. These types of losses are hidden and not physically seen, having overcome life-altering losses of her own. And using, next we have Dr. John Barker. Dr. Barker, BSc, MBBS, MRCOG, and FRCOG. Dr. Barker is currently a UE lecturer and associate consultant at the QEH, Queen Elizabeth Hospital in Barbados. He has been a consultant in the UK and is currently a consultant obstetrician and gynecologist and the director at JRB Medical Center in Barbados. In Barbados, he has formed an endometriosis center and is part of a multidisciplinary team designed to treat deep infiltrating endometriosis. His surgical interests include advanced laparoscopy, and hysteroscopy techniques. He has also performed the first laparoscopic hysterectomy for endometrial cancer in Barbados. Thank you, Dr. Barker, for joining us this afternoon. Our third panelist is Ms. Charlotte Byrne, and she is the founder and clinical director of the Fertility Center and Weight Management Center in St. Lucia, the first facility of their kind on the island. She was born in the UK and raised between England, Grenada, and St. Lucia, and she began her journey into fertility care over 15 years ago with a strong interest in type 2 diabetes, PCOS, and infertility. A holistic fertility practitioner, Charlotte combines conventional medicine with herbal, holistic, and mind-body therapies, ensuring that patients receive comprehensive support mentally, physically, and emotionally. She is additionally qualified in fertility acupressure, advanced herbalism, and pharmaceuticals, with further studies completed at the London School of Hygiene and Tropical Medicine and at Leeds University in the UK. Her areas of expertise include PCOS, male and female infertility, hormone disorders, and weight management. Under her leadership, the center has expanded its services to Grenada, Dominica, and Carriacou, and has earned recognition for its high standards of care and integrative approach to reproductive health. And Charlotte, we thank you so much for being with us this afternoon. And our fourth and final participant is Dr. Azizi Popo Hippolyte. Dr. Azizi Kezia Popo Hippolyte, is an aspiring endocrinologist who recently graduated with first-class honors from the Latin American School of Medicine in Havana, Cuba, achieving an outstanding GPA of 4.98. She credits her success to God, the support of family, hard work, and perseverance. From a young age, Dr. Popo Hippolyte has been passionate about helping others. During her final year at St. Joseph's Convent, she gathered a group of friends to form the Disease Awareness Organization, DAO, raising public awareness of various health conditions. Around the same time, she volunteered with and became a member of the Diabetic and Hypertension Association and its youth group, which further sparked her interest in endocrinology. As an aspiring endocrinologist, Dr. Popo Hippolyte has had the opportunity to shadow several prominent endocrinologists, including Omeda Torres Herrera, former president of the Cuban Endocrinology Society. These experiences allowed her to deepen her understanding of endocrine disorders and their impact on both individuals and society. Dr. Popo Hippolyte has a particular interest in endocrine-related conditions affecting women, including Polycystic Ovary Syndrome. Recognizing the rising prevalence of PCOS, especially among her close friends, she is honored to speak during PCOS Awareness Month to educate the public, both men and women, on early detection, management, and prevention of potential complications. Additionally, she will discuss the relationship between PCOS and sleep exploring how each can affect the other. And thank you, Dr. Popo Hippolyte, for being with us today. So these are our four finalists, panelists this afternoon. And we are very, very, very excited to have them with us. Please feel free to share your questions in the chat as we move along, and I'll be sure to note them down. Please be mindful of how you interact with other members of this community. This is a safe space, and we want everyone to feel comfortable. We are all here to learn, to share, and to support each other. Now, our first presenter on our list this afternoon is Miss Brenda Roach.
Hello, good afternoon, everyone, and thank you, Beverly, for that introduction. And thank you to Iyanola Wombmanhood for always thinking of me and inviting me. So I'm just going to share my screen. Just give me a few minutes. Let's go back. All right. Okay, so my objective today is to share about the links between PCOS and mental health. I know that we've all heard about mental health, and so I thought that this was a good idea for Iyanola Wombmanhood to bring this to the fore as we discuss PCOS. So some of the objectives that we'll be looking at. So mental health disorders commonly associated with PCOS. So what mental health disorders come up when we think about PCOS? Some signs and symptoms of these disorders, the impact of these symptoms on daily life. I think that's quite important. How do our PCOS symptoms impact daily life? How living with a chronic illness can exacerbate mental health challenges, general approaches to treatment for these disorders, and practical strategies for PCOS warriors to maintain a healthy mental state. And notice I said warriors because, yes, you all are truly warriors. So I'm going to start off by looking at common disorders associated with PCOS. So we're going to hear a lot about PCOS, what it is, what are some of the signs and symptoms of it. So that's not what I will get into with this presentation. This presentation is mainly to focus on the mental health aspects of PCOS. Okay. So straight away, when we look at this slide, we can see some common disorders that I think many of us have heard about. So we have the depression, we have the anxiety. Those are commonly interchangeable or utilized terms that we've all heard about. We have the eating disorders, we have bipolar disorder, and we also have personality disorders. So I want us to explore each one of these, and we can look and see how PCOS is associated with some of these disorders. And remember to put your questions in the chat, and hopefully we can get to them at the end. So there are many factors that contribute to the depressive symptoms some may experience with PCOS. So depression is the first one we're going to look at. So overall, depression is common due to the biological, psychological, and social factors that women face. Okay, so there are hormonal imbalances, so stressors such as negative body image. Not sure how many women struggle with that, but I know a lot of women, especially with PCOS or any kind of chronic illness, they struggle with negative body image. Infertility is a big one because we all know society has taught us that when we become adults, you know, we get married, we have the 2.5 kids, we have the house, right? So infertility, the possible negative impacts to relationships and the feelings of stigma. When we think about PCOS, I want us to always remember that this is not an individual disease. This is a family or societal disease. So some of the biological factors, PCOS involves the dysregulation of the hypothalamus gland. And I know the other doctors on the panel will get into the details as it relates to that. But what happens is this is crucial to the neuroendocrine system that regulates our reproduction by controlling sex hormones and the menstrual cycle. And then, of course, this then leads to imbalances, which can impact our mood regulation. Inflammation Chronic inflammation is very common with PCOS, which can result in physical and psychological symptoms. So let's take a look at the psychological factors that can be impacted by PCOS. So remember, I would have mentioned the negative body image. So there's obesity, there's the unwanted hair growth, there's acne. So imagine you went through acne as a teenager, and then as an adult now, you have adult acne. And these are some of the signs that can then lower a woman's self-esteem, and it can increase symptoms of anxiety and depression. The infertility. This causes emotional distress because, like I mentioned before, society has taught us women that, hey, when we get to a certain age, we're supposed to get married, we're supposed to get our house, we're supposed to have our career, we're supposed to have the 2.5 kids. So when that does not happen in that order, then we feel as though something is wrong with us, right? So the emotional distress that can come with infertility, there's stress, there's anxiety, there's feelings of loss and unworthiness due to societal pressures as well as our own personal pressures. Because once society puts the pressure on our families, then of course our families put the pressure on us. And again, it's not intentional, but that's just how it goes. Then there's the stigma. So the social stigma associated with PCOS can lead to feelings of isolation. So of course, if you are feeling like you are bloated, for example, or if you are feeling that, you have too much acne, so you don't want to really be seen, obviously that means you're not going to go a lot. So isolation. Then comes the social anxiety and the diminished sense of self, which in turn would impact a woman's identity and overall mental well-being. Some of the social factors can include the social isolation. So due to the burden, both of physically and emotionally, will lead to reduced social activity, resulting in feelings of isolation, impacts to relationships. So of course, remember we mentioned the sex hormones. So then obviously, if you're feeling that way, you may not want to have sex with a partner, for example. And how does that impact your relationship? Because of course, intimacy is important to a relationship. Therefore, not being able to show up in a way may be stressful to both parties. The infertility will also impact your family life. What about work? Obviously, due to a chronic illness or even the chronic nature of PCOS, it can impact your ability to participate holistically in your work life, right? There are going to be times where you're going to have to stay home from work, you're going to have to call in. Will you have an employer who is sympathetic or empathetic enough to understand that, hey, this is not something that you're doing intentionally, but this is just how it is due to the chronic illness that you're facing. So then, of course, it can impact your career building capabilities. Social expectations, the personal, family, and societal pressures about femininity and reproduction further enhance the distress caused by PCOS because of the infertility and maybe the hair growth. And so let's come down. So let's take a look at anxiety. So we saw depression, but let's look into anxiety a little bit. So some of the physical symptoms or manifestations, such as the acne, the excessive hair growth, the weight gain, and the infertility, can negatively impact a woman's self and body image, self-esteem, and quality of life, which can lead to increased stress and worry. Hormonal imbalances, and these hormonal changes can result in mood disorders. Then there's the psychosocial factors. So the feelings of being different, the stigma, and the overall struggle to find help can work through these challenges can contribute to the distress that you will feel when battling PCOS. What are some of the signs and symptoms of this anxiety, you might ask? So in general, like we discussed with depression, it's similar. So the excessive worry, this restlessness, this irritability, which can be exacerbated by PCOS, symptoms of the acne, unwanted hair growth, the weight gain, which in turn contribute to the body image distress, social anxiety, and sleep problems. And we have someone who's going to talk about sleep a bit later on. But you can see how all of these signs and symptoms have a ripple effect, right? So the specific PCOS triggers for anxiety can look like Body image concerns, so the social anxiety. So how will I be perceived by others? When people see me, what will they think? Lack of control over one's body and health. So obviously feeling as though your body is betraying you, right? Simply. Why is this hair coming up all of a sudden? Why is this weight coming on all of a sudden? What is my body doing to me? Eating disorders. So I'm not sure how many of you thought about um, eating disorders as it relates to PCOS, but um, eating disorders are behavioral conditions characterized by severe and persistent disturbance in eating behaviors and associated distressing thoughts and emotions. So we can imagine that when we have a chronic illness happening, how we eat typically is dependent upon our mood at whatever given time, right? So they can be very serious conditions affecting physical, psychological, and social functions. So types of eating disorders, and I think we've heard about some of these before. So there's the anorexia nervosa, there's the bulimia nervosa, there's the binge eating disorder. And we'll explore each one of these. So the anorexia nervosa is characterized by self-starvation and weight loss, resulting in low weight for height and age. Anorexia has the highest mortality of any psychiatric diagnosis other than opioid use disorder and can be a very serious condition. Dieting behavior in anorexia nervosa is driven by an intense fear of gaining weight or becoming fat. So you can imagine if you have PCOS and then you have the increased weight gain, how anorexia will tie into this, right? Because of course there's that intense fear that may come up with gaining weight all the time, becoming fat, and then how will I be perceived when I get into social settings, for example? Although some individuals with anorexia will say they want and are trying to gain weight, their behavior is not consistent with this intent. And then there are two subtypes to anorexia. So there's the restricting type, and then there's the binge eating type. And I think we may be familiar with both, but I know that a lot of people will know about binge eating for sure. So let's look at the restricting type. So this is when individuals lose weight primarily by dieting, fasting, or excessively exercising. So we know we may come across people, some maybe our friends, who excessively exercise. So if they exercise in the morning, then they have to exercise in the evening as well, or they may have to exercise sometime during the day as well. Um, or they're always on some kind of fasting diet so that they don't gain this excessive weight that comes with PCOS. For some people, again, it's not across the board. Then we have the binge eating or purging type, in which persons who engage in intermittent binge eating and or purging behaviors. And what does that look like? What might that look like? So again, based on your mood. So for instance, you may say you don't eat anything for the day. Then the evening time, after you've had such a stressful day at work, you decide you're going to come home and just start binge eating. And that may look like you're eating a whole lot of carbs, for example, because they give you a bit of comfort. So that's what we would call binge eating. Bulimia nervosa. So individuals with bulimia typically alternate dieting or eating only low-calorie safe food. So we know people who typically calorie count a lot. Not saying that that is a negative thing, but also saying that it can be taken to the extreme. Okay. Forbidden high calorie foods. So binge eating is defined as eating a large amount of food in a short period of time associated with a sense of loss of control over what or how much is eating. Binge behavior is usually secretive and associated with feelings of shame or embarrassment. Binges may be very large and food is often consumed rapidly. And again, because that is associated with feelings of shame and embarrassment, it means then that you may be binge eating by hiding. So you're going to your bedroom and you would eat everything that you have in your bedroom, or you store things in your bedroom so that you can eat everything there. Binges occur at least weekly and are typically followed by what are called compensatory behaviors. So to prevent weight gain. And these can include fasting, vomiting, laxative misuse, or compulsive exercise. Binge eating is also seen as a disorder, along with anorexia. So I won't go into too much more of that. Bipolar disorder. And we know that this disorder or this term is interchanged a lot with a lot of people. But it's a serious mental health condition characterized by periodic intense emotional states affecting a person's mood, energy, and ability to function. And these periods lasting from days to weeks are called mood episodes. And so they can be manic episodes or hypomanic when the predominant mood is intensely happy, or irritable or depressive episodes when there is an intensely sad mood or the ability to experience joy or pleasure disappears. Studies show, and I'm going to read this, that women with PCOS have a significantly higher risk of developing bipolar disorder compared to those without PCOS. The contributing factors for this are inflammation, the psychological impacts to the chronic stress, and the burden of managing the condition. Symptoms can include the insulin resistance, which affects mood regulation, with the chronic inflammation being linked to increased levels of anxiety and depression. So let's take a look at what are the impacts to daily life, since we've taken a look at the disorders that can be associated with PCOS. So I think from what we have explored so far, it might be pretty easy to spot the impacts to daily living for not only women, but also to partners, spouses, families, and to society at large, right? Most of what we will discuss on this slide will be repetitive because it will encompass most of the areas that we've already covered. So the physical impacts, irregular periods. So this can come with its own set of stress, as the not knowing when a cycle will appear and whether it will be painful or not can cause anxiety. The skin and the hair issues, so acne at any age is a pain, am I right? Couple that with hair loss or can severely impact a woman's self-image in a negative way, causing them not to want to be seen and can lead to distress. And of course, this will impact anyone's mood, as we're all human, right? Then comes the weight gain or the weight loss, whichever one you're struggling with. And again, that can impact your image, your self-image. And we know how we are in the Caribbean. We can be quite nosy and we can just say things that can be quite hurtful, even if we don't intend them to be hurtful. And then, of course, the infertility. And again, this can be a particularly sore subject for women, especially for women who have been trying and have been unsuccessful. Psychological impacts. So we would have mentioned some of the psychological impacts in the previous slide, so I won't go into those in detail. What I will say, though, is that these are possible mental health outcomes. This does not mean that all women will develop them. Okay, so even though you have PCOS, some of you may be able to live full-fledged lives. It does not mean that you will come down, have a mental health condition as a result of having PCOS. But we do understand that women with PCOS are at higher risk for the depression, anxiety, and eating disorders. Of course, the body image issues can negatively impact a woman's confidence and mood. The feelings of stress associated with fertility challenges and body image can lead to social stigma, which will manifest in isolation. And then, of course, the social and the personal impacts. So, of course, we spoke about relationships, we spoke about families, and by extension, that strain can then lead into society. So families, the fertility struggles or challenges that can place pressure on a woman and by extension their partner. On top of this, a woman may be unable to envision a possible future being married due to many struggles they face. Community. So due to the impacts of the symptoms, there may be a limitation to the extent to which a woman can participate in events that they may be interested in, creating the isolation. So how living with a chronic illness can exacerbate mental health challenges? It's never easy, right, for anybody who is struggling with a chronic illness. But it can make you more susceptible to mental health challenges due to the physical pain, the fatigue leading up to feeling frustrated and sad. Many clients mention feeling like a burden to those around them, whether that is because they need constant assistance with managing their symptoms, the unpredictability of PCOS, the financial strain it can create, and the social isolation from activities. So the emotional and psychological impacts can look like grief and loss. So obviously, if you are struggling with PCOS, the infertility, that is something that you would have to grieve. You grieve who you were before you were diagnosed with this condition. Grieving future plans. So of course, like I mentioned before, we grew up in the Caribbean for many of us. And that means then that our life plan was pretty much laid out for us. So we have to grieve that, our future plans, those visions we have for ourselves, which can lead to feelings of hopelessness, frustration, and sadness. Stress and anxiety, so continuously keeping up with the medical appointments, the financial strain that can come about as a result of that, the unpredictability of the condition will cause stress and anxiety. It's common for anyone struggling with a chronic condition to experience depressive symptoms due to feeling of lack of control, the inflammation, and the pain. And of course, the long-term and uncertainty of the condition can lead to increased sense of loss of autonomy and a sense of helplessness. And then the social and behavioral impacts can look like social isolation due to the pain, the fatigue, the limited mobility, feelings of loneliness, lack of social support, reduced quality of life, because of course you're not able to participate in things that you would like to participate in, the low self-esteem due to the body image, the negative body image, the impact of daily functioning, the reduced daily functioning due to limitation on physical activities, and the chronic pain can lead to emotional and psychological strain. What are some of the general approaches to treatment? The biopsychosocial framework is one that works best. So working with a multidisciplinary team. This means looking at the biological factors, the psychological factors, the social factors, and the medical, and not just the medical factors alone, right? So of course, the biological factors, looking at the hormonal dysregulation, the psychological factors that can include the body image issues, the embarrassment and the stigma, discussing menstruation and just having that general discussion, which can still be a taboo type topic. The social factors of stigma, the discrimination and the negative experiences women face. Because of course, if you have to miss work a lot, then of course discrimination will come into effect, because employers will not want to employ someone who is not productive, what they would term productive enough. Of course, healthcare, as it relates to the timely diagnosis and effective treatment, can also hamper screening and diagnosis. This will be done by a medical professional, lifestyle changes and adjustments, so diet and exercise, ongoing medical care, mental health support is also very, very important. Support groups, if there are any. And of course, we know in Barbados, we have the Barbados Association of Endometriosis and PCOS. In St. Vincent and the Grenadines, they have the Association of Endometriosis, Adenomyosis, and PCOS. And of course, the Iyanola Wombmanhood in St. Lucia that is with support as well in terms of group support. Practical strategies. PCOS is a whole body condition and as such needs to be treated that way. So incorporating exercise, maintaining a balanced diet, prioritizing self-care through hobbies and relaxation, mind and body lifestyle strategies, physical activities that will help to improve your mood, self-care. We know that's a buzzword, but doing things that involve freeing your mind from the anxiety that is surrounded by PCOS. So whether that is hiking, walking, art, coloring, anything like that, mindfulness. So whether you're going to do some yoga or meditation or some deep breathing, psychological and emotional support, of course, where you get to explore your feelings in a safe space. And then, of course, groups, if you can get into groups as well. Medical and holistic care, of course, you're going to consult your medical professional and they will give you, I would like to think they would give you a comprehensive treatment plan that will help to work through what you're experiencing. Managing PCOS is my last slide because I think I've run over time a little bit. So managing PCOS, food, so protein-rich foods or meals, so whole foods, and limit any added sugars. I know for me, sugar is an issue, but I try to limit it as much as possible. So try to have a more protein-rich meal and whole foods, lifestyle, consistent sleep, and daily movement. Movement every day. And movement every day does not necessarily mean you have to go to the gym, but movement every day can look like just going for a walk. Supplements, so probiotics and vitamin D can help to decrease the inflammation. So those types of multivitamins that you can get. And some small hacks like smoothies, green teas, cinnamon, seeds, those types of things that can assist. And then my references, and I think that's it for me. So I will stop sharing.
Thank you, Brenda. Thank you so much. This was so informative. And you said something at the beginning of your presentation that kind of ties in everything that you spoke about. You said PCOS is a family/societal disease. It is not an individual disease. And you showed us, how what that entails by, explaining not just the biological, but the societal and the psychological factors that are that come about because of PCOS. And you gave us so much information on not just managing PCOS, but understanding that, different things happen. Yes, there might be other factors that might, trigger anxiety or depression, but a reproductive disease like PCOS can also trigger these issues and exacerbate them even more. So we thank you so much for this, comprehensive and detailed presentation. And as you highlighted, a comprehensive treatment plan is necessary for individuals who are living with PCOS. So it's not just about the food and the exercise, but you have to incorporate the mental, the psychological factors. You need familial support. You need support in the workplace. And that's why I'm such a big advocate for policies at the national level that can impact the lives of women who suffer, not just on the individual level, but it can have an effect on everybody. And so our leaders, our policymakers also need to be in tune with the issues that women are dealing with so that there are policies that provide support for women in the workplace, at home, in social settings, wherever they go. So thank you so much, Brenda, for your informed and detailed presentation. So we will move on to Dr. Barker, Dr. John Barker, who will be presenting today and giving us more of the medical side of things. So Dr. Barker, on to you.
Thank you. All right. Can everyone hear me?
Yes.
Yes.
Good. Okay, so we're going to look at some PCOS-linked conditions. I try not to go too much in detail due to the audience, so should be very concise. Now, polycystic ovarian syndrome commonly is a common condition caused by initially a hormonal imbalance. It's associated with increased hair growth, acne, irregular menses, and may affect fertility. In UK, the incidence is around 1 in 10. The World Health Organization says that up to 70% of women still remain undiagnosed, and it affects 1 in 4 women between 18 and 35 years. The incidence is unknown in Barbados, and the main crux of the matter is associated hyperinsulinemia due to increased insulin resistance. And this is what drives everything in relation to the symptoms. Now, when a patient comes in, usually give a history, and when we examine them, and then there's an examination. So the usual history is either irregular menses, no menses at all, acne, oily skin. Sometimes they might have hair all on the abdomen, and then what they might tell you is that they're trying to get pregnant and can't get pregnant. So that's the usual history that you would get. In terms of the diagnosis, the Rotherham criteria is how we diagnose patients. And essentially what we need to diagnose is ultrasound evidence of polycystic ovaries. And essentially what it looks like, the ovaries, you get 1 to 2 millimeter cysts appearing in the periphery of the ovary. And this is how we diagnose it on ultrasound. Signs or symptoms of androgen excess. So this would be the oily skin, the acne, and sometimes the hair on your chin. Sometimes it can be just slight, or sometimes it can have an actual beard and irregular menses. Now, to diagnose, you need 2 out of 3. And the paradox is that sometimes you might have normal ovaries, but you have the other 2. So sometimes patients may not be able to get their head around that one. Now, these are the polycystic ovaries. And so this is the ovary here. You see my cursor going. And these are the small peripheral cysts. So once you see that as diagnostic of a polycystic ovary, on the other hand, this is it here as well too. So and they're usually bilateral, meaning left and right, because most normal women will have a set of ovaries, which should be two. So you usually have bilateral polycystic ovaries. Now, in terms of when we see these patients in clinic, what we try to do is to inform them of the long-term implications. And this is a conversation or counseling that we have on the first day. And what I will tell them is that they are at risk for type 2 diabetes, cardiovascular problems due to increased high blood pressure. Sometimes the hyperinsulinemia will cause increased high cholesterol, and that would increase the incidence of cardiovascular disease. There also to discuss the risk of endometrial cancers and hyperplasia. And there will be an increased risk of two of these if they have less than 3 to 5 cycles a year, meaning that the minimum amount of cycles that you should get would be at least 5. This is also to explain to them. The problem is that most of the time the patients would present in their 20s or 30s. So at the time, these issues that they would develop will be within the next 15 to 20 years. So you have to tell them that whatever you're telling them, they have to take you seriously, because it will not be an issue now when you diagnose them, but in 15, 20 years, it will definitely be an issue. And they also to have fertility issues. Some patients might have to end up with my IVF colleagues as well. And as Brenda would have elucidated, to depression and mood swings. And this would be a collection of physical appearance, can't get pregnant, weight issues, then added family issues as well. Now, this is the RCOG handout. So this is a handout that I will usually give to patients newly diagnosed with polycystic ovarian syndrome. In terms of blood workup and stuff, we usually do a prolactin. Prolactin is a hormone that, if it's increased, will lead to irregular or absent periods. And if it's extremely high, it can point to a tumor in the pituitary gland. And we also do testosterone screening as well. And this is to make sure that the testosterone level is not very, very high, because sometimes that can point to another tumor causing that as well too. So in terms of the counseling, we have to do a number of blood tests just to make sure that there's nothing sinister going on. Now, in relation to the diabetes, 1 in 2 women with PCOS going to develop diabetes at some point. And this risk of developing diabetes is if you're over 40 years of age, you have a family history of diabetes, or you had what we call gestational diabetes, whereby you had diabetes during pregnancy. And if you have an elevated body mass index over 30. So if these risk factors on their own increase the risk of type 2 diabetes, if you have PCOS, then your risk will be significantly increased due to the PCOS and these factors as well. And in terms of the cardiovascular issues, due to the elevated BMI and hyperinsulinemia, they usually have a high cholesterol levels and they have high blood pressure. This in turn would then give you an increased risk of cardiovascular disease. So these patients have increased incidence of stroke and coronary vessel disease, and this would eventually end up into having basically a heart attack. Now, in terms of the fertility aspect of the PCOS, it can impair fertility up to 70%. Essentially, what you have is anovulatory cycles, meaning that you're not ovulating. And if you're not ovulating, then that means you can't get pregnant. Now, in terms of the what my IVF colleagues will suggest is if the BMI is over 30, and we try to get the BMI down to 30 before they can do anything. And diet exercise is the main factor in this. And essentially, what it does is once you lose the weight, then you're able to ovulate. And some patients will tell you that they had irregular periods, but then when they found that they found about lost about 5 or 10 pounds, the periods were regular. Then you have to explain to them, well, you have to keep this weight because if you put on any other weight, then the periods more likely would become irregular. More than likely, they would have been ovulating now since they have lost the weight. There are some studies that show that if you give inositol, this is of some benefit. And the important thing with the PCOS is that if you give any kind of ovulation induction, sometimes you can get multiple follicles being developed. So as a result, you will have to have ultrasound guided guidance of these follicles so that you don't get any other issues. Sometimes you can put them on metformin as well. And the metformin, but also to try to control the insulin levels, in addition to helping the patient to lose weight. If you have any issues, then what I usually do is refer to a IVF facility for further management or to a gynecologist with fertility specialist interest. The hardest patients to treat actually are not the ladies with the elevated BMIs. Is actually the same ladies with PCOS because they don't their mechanism doesn't seem to be driven by the increase in size. Now, in relation to the endometrial issues, this is mainly due to the irregular shedding of the lining of the womb or the endometrium. And what you find in PCOS ladies is a high estrogen levels. Now, what happens is that it's like if you're on steroids. So when the lining is exposed to high levels of steroids, it just grows, but it doesn't shed. And the shedding is usually due to the progesterone effect. However, this is absent. So as a result, the lining of the womb becomes progressively abnormal. So in the spectrum, you would get the thickening of the lining of the womb. And then after a few years or decades, you're more at risk for endometrial hyperplasia, which is essentially can be simple. If it's simple, then you put in a Mirena coil. But if it's complex, then you have a 3% risk of endometrial cancer. Or and then what happens is that you get the spectrum going from hyperplasia to endometrial cancer. This is due to the estrogen, the high levels of estrogen. Of note, it can increase the risk of endometrial cancer up to 3 to 5 times that of the normal population. So as a result, you have to emphatically tell these ladies that we cannot just leave you on nothing. We have to treat your periods in relation to either putting you on the oral contraceptive pill, Mirena weight loss, because if I diagnose you at 15, 16, 17, then you have 40 years, well, up to 35 to 40 years to become menopausal, and that's a long time. So it's best to decrease your risk at a younger age. The psychological issues will be due to increased BMI, fertility issues that we mentioned, the family, sometimes it can be very insensitive, the frustration of the ladies in relation to the physical appearance and not getting pregnant, the irregular heavy bleeding that they may have, and the hirsutism, which is the hairiness that they might have. So this would be facial and or body hair. Now, in terms of the treatment to prevent long-term consequences, we either put you on the Mirena coil, which is a coil you put in the womb, and usually it releases a chemical called levonorgestrel, and that releases over 5 years. And essentially, what that does is to thin the lining, so you don't get any stimulation of the lining. The contraceptive pill, either oral, either combined and or progesterone, essentially what that does is thin the lining if you use the progesterone only, which works like the Mirena coil, or the combined pill, which has both estrogen and estrogen. So essentially what it does is causes the shedding of the lining of the womb, so that decreases the risk of endometrial cancer. Now, in terms of the hair, because I didn't mention it early, what we can do is, depend on where the hair is, the best thing that I would recommend would be laser, because plucking or shaving causes more harm to you in relation to scarring and stuff. So we would recommend either lasering. The only issue is that the medication that we use, like in the UK, is something called Viniqua, which actually thins the hair. So then it decreases it over time. The only other alternative in terms of which can or may help, but that's mainly acne-wise, will be, in terms of the pill, will be Yasmin, because sometimes that is shown to decrease the amount of acne. No, healthy lifestyle, as in anything, diet, exercise, we usually would advocate that. And usually every time a PCOS patients come to the office, the first thing I'll do is check the weight to see if they are adhering to the diet. And the problem is that a lot of people fall back into their old ways, and as a result, you will find that these patients will come back to you without losing weight for a while. Some lose, but the majority, I would say about 60, 70%, don't actually lose weight. And that might be a multifactorial thing in relation to if they have any depression like symptoms, or if they just don't care. But usually some of them, the ones that who don't lose, when you talk to them, they don't really try to lose the weight. I'm not sure if that's the same with any of the other professionals in the group. And counseling is very important. You have to make these ladies aware of the long-term risks, because at the end of the day, you're going to get diabetes if you don't watch yourself. That will create renal problems, kidney problems, vascular problems, increased levels of stroke, increased levels of amputation. So you have to try and counsel them about the long-term effects. You have to let them know that PCOS is just not the polycystic ovaries. It's a spectrum of disorders that will lead to your demise if not taken seriously. But the thing is that it happens over a long period of time. So people don't get the urgency of the disorder. Um, Multidisciplinary teams may have to be involved in the counseling as well. One of the people who I would be frequently referring to is the endocrinologist, especially if you have PCOS and like high prolactin levels. So usually I let some of my colleagues co-manage these patients as well. In terms of the weight loss, it lowers the insulin resistance and the developing of diabetes, lowers the risk of heart problems, lowers the risk of cancer, of endometrial cancer, more regular periods, and increasing chances of being pregnant. And also it leads to a reduction in the acne and a decrease in excessive hair overgrowth. And also to lastly improve mood and self-esteem. So it's very imperative, if the BMI is elevated, you have to encourage these women to try to lose weight, because the health benefits are tremendous. Is there a cure? No. So that's why counseling is of the utmost importance. Any questions?
We did have two questions from two of our, well, now we have three. The
Mhm.
first one was from Joanne, and she says, I'm on metformin 3 times a day, which means my first tablet is 4 a.m. But when I take it at 4 a.m., I end up feeling sick because my sugar level is already at 5. Should I stop taking it at 4 a.m. and just take it twice a day?
Right. With metformin, if she starts, the usual dose is 500 3 times a day. But if you realize that you are feeling ill in the morning, then I would decrease it to 2. But then it also too depends on in relation to the other things that she is doing in relation to diet, exercise. Or what she can do is if before she takes, so she says she takes the first and the second one at 4 in the afternoon or 4 in the morning.
She says her first one is at 4,
Hmm.
but she feels sick and her sugar levels are high. So should she stop taking it at
Well, no,
4?
no, no. But I would suggest that she takes that first one with food because if you take it on an empty stomach, you will get dizzy or some gastrointestinal upset.
Okay.
So she gotta take the first one with food. If she just takes it by itself, yeah, she asking for trouble.
Okay. All right, Joanne, we hope that response is helpful. The second question was, I would like to know about insulin resistance and how to manage it. That was from Carla.
Right. The insulin, the issue is that you have high levels of insulin and you get high levels of insulin resistance, whereby the insulin when it binds to the receptors for some reason it doesn't act as normal. So you need these high levels of insulin to produce the same effect. So what I find is that if you diet exercise, then you will decrease your sugar levels, you will decrease the hyperinsulinism because the sugar levels will be decreased and adequately controlled. So in terms of the to try to mitigate against the elevated levels of insulin, then you have to be eating healthy and you have to be eating and you have to be exercising to decrease the hyperinsulin. Because if your diet is not good, then that means that you automatically will have higher insulin levels. And then as a result, your cells in your pancreas are going to be overworking, then the burnout. So that's how you get the diabetes. But if you're not eating as much as you process refined foods and you're exercising, it means that your blood sugar levels will be within normal. So that means that will try and bring everything down.
Okay.
The hardest thing for people to do is to fast.
Yeah. So regulating insulin, or
Yeah, be
rather
diet, exercise,
managing,
and fasting.
right. Okay, so we have a few more questions, but we're gonna save them for after to our Q&A. So thank you so much, Dr. Barker. This was so
No problem.
informative. And we have so many questions. I know that a lot of our participants have medical questions. I think one of the most pressing questions is how to manage PCOS. What are the things that we need to know to do, or how should we change up our medicine, or the things that we take to manage PCOS. So please, if you have any more of these questions, please hold on to them, post them in the chat. We're going to um, present them at the end of the webinar. And now we're going to move on to Charlotte Byrne, who's our third presenter this afternoon.
Good afternoon, everybody. Good afternoon to my colleagues, and of course to the amazing Iyanola Wombmanhood and all the great things that you guys do. So today I'm going to talk about PCOS and the link to fertility, or infertility, should I say. So if you're considering getting pregnant and you have PCOS, it's very important to talk to a medical practitioner to understand what the complications could be. So for example, if someone has PCOS and they are trying to get pregnant, they are more at risk of having an early miscarriage. They are more at risk of having gestational diabetes and also premature delivery. Also, because PCOS is a cardiovascular, it can lead to cardiovascular diseases. High blood pressure should be monitored within pregnancy as well. So we're going to look at ovulation and how PCOS affects ovulation. So PCOS can affect ovulation. Ovulation is when an egg is released from the ovaries. This should be happening on a monthly basis. In about 80% of cases with PCOS, this doesn't happen. And if you don't ovulate, obviously you will not get pregnant. There is no egg to fertilize. So we want to make sure, we need to check to see if someone is ovulating. So when the egg is mature enough, it is released from the ovary. Now, problems with high androgen levels, which is the male hormone, can prevent that egg from maturing enough to be released down the fallopian tube. And if it doesn't mature enough, it becomes a very immature follicle and it sticks around the ovaries. And that's what we see on the ultrasound, which we call cysts. They are immature eggs. So at this point, they're not coming down the tube. So it wouldn't matter how many times you would have intercourse trying to get pregnant, no pregnancy will occur if you are not ovulating. So these high levels of androgens, which are male hormones, they affect the menstrual cycle, ovulation, and we also have the case of insulin resistance as well, which can stop ovulation altogether. The increased levels of androgens, we want to prevent that so that we can actually increase the progesterone and balance the hormones so we can obtain ovulation. So how do we check to see if our bodies are working properly? So what we do at the Natural Fertility Centre, I'm going to go through what we do in our consultation. It's a holistic consultation and ways that we look to see whether ladies are ovulating and what we can do to assist in ovulation. So factors affecting ovulation, we need to check first of all, are you ovulating and how we can find this out. So we use ovulation tests. They are a test that picks up the luteinizing hormone, LH. It's a hormone that spikes just before the egg is released. So we use these tests, we work out your fertile window. So every month, a woman will have about a 10-day fertile window. So we work this based on your last menstrual cycle. We will give you a date to start testing, and you will test for 10 days in a row, or even longer, because sometimes with PCOS, we can't really, we can't notice your cycle because it may be very irregular, or you may not have a period for, say, 6 months. So sometimes we have to induce a period to actually get a cycle so we can start testing for ovulation. So we test for about 10 days. We use the second morning urine, and it's very much like a pregnancy test that you would urinate into a plastic cup. You dip the test stick into the urine up to the black line, and then you put it on a flat surface. After about 5 minutes, my clients will send me a picture of their test, and I will just confirm whether it's positive or negative. So if it's negative, I will let them know. If it's positive, and obviously if they're trying to get pregnant, I will say, have sex. Have sex today, have sex tomorrow. Once that egg is released from the ovaries, we have about 12 to 48 hours to fertilize it. So we really want to start having intercourse as soon as we get that spike in that luteinizing hormone. As I said, about 70 to 80% of persons with PCOS do not ovulate. So we have to make sure that we counsel and advise that don't be surprised if you don't get a positive ovulation test. That is common with PCOS. And there are several factors that we have to look at to help someone to start ovulating and to get their periods regulated as well. So we're going to look at natural ways to improve fertility with PCOS. So I'm going to start with balanced diet and exercise. I'm a nutritionist as well. So we try to look at someone losing 5 to 10% of their body fat, their weight loss, to help to regulate ovulation and the menstrual cycle. The balanced diet that I use personally with my clients, and I find it works really well, is to cut out 3 of the main enemies, which I call 1, white sugar or any refined sugars. So this comes in the form of a lot of sugary drinks that we have in the Caribbean. So Vitamalt, malt. These are very sugary. A lot of people use them to substitute for meals. So it's like putting a whole ton of sugar in your body instead of actually eating something healthy. A Vitamalt actually has 43 grams of sugar, which is very surprising to many people. So that's like drinking 2 bottles of Coke, for example. So yeah, so it's very much full of sugar. The sugar content is very high in things like local juice, especially if you don't make it yourself. If you buy it out, it's full of a lot of sugar. So I always recommend that ladies squeeze fruits and add water and don't add any sugar and use more honey to sweeten it. I only recommend drinking water, coconut water and flavored teas, because any other fruit juice, cans of fruta, the box drinks, sodas, all of these things are full of sugar. So I recommend firstly to look at the drinks, because the drinks in the Caribbean have very high sugar content. So we stick to water, coconut water and flavored teas like peppermint tea, ginger tea, green tea, just no sugar. We are allowed to have flavored teas, but we just add honey to sweeten it. We don't use refined sugars. Okay, we are not allowed to have white flour. So white flour makes up most of the Caribbean diet as well. So a lot of things like bakes, pasta, pizza, even roti shells, noodles, chow mein, we cut these out of our diet as well. This is the one that my ladies find the hardest, but this is actually where they lose the most weight and they see their cycle start to regulate again. And the last one is white rice. I don't recommend white rice. We switch to brown rice. So you're probably wondering, well, what can you eat? You can have lots of peas, beans, and lentils. You can have vegetables like broccoli, spinach, kale, cabbage, pumpkin. You can have any type of meat or fish. You can have turkey, pork, chicken, ham, sausage. I'm okay with these as long as they're not fried, so they can be baked, steamed, grilled, boiled. Okay, brown rice instead of white rice, and you can also use whole wheat instead of white flour. So for example, some of the shops sell the whole wheat tortilla wraps, so you can do tuna fish and sweet corn wraps, ham and cheese wraps, scrambled egg and tomato wraps, and that's a healthy alternative to using white flour. White flour spikes your blood sugar the same way as sugar does. And because PCOS is an insulin disorder, we don't want too many blood sugar spikes at this time because it does affect the hormones and it does cause the weight gain as well. So we are allowed vegetables, salad, brown rice, meat, fish, and of course, peas, beans, and lentils. And I do allow couscous and quinoa as well. So what we do is we have a healthy eating support group. And if anyone on this group would like to be added to it, it's a WhatsApp group for ladies that have PCOS. And we share meal plans every day, what we've cooked, you know, what we're proud of, what we want to share with other people, smoothie ideas, for example, breakfast ideas. And it's a very motivational group. So anyone here would like to be added, just put your number in the comments or send to me directly and I can add you to that later on today. That's fine. Another way to improve fertility with PCOS is actually to start thinking about having children younger, as Dr. John Barker did mention. Once you get over 35, age actually becomes a factor. So we don't want to have PCOS as a problem and age as a problem. So if you can start trying to get pregnant, if it's possible, a little bit younger, you have years then if you find there is issues with ovulation, for example, or if you do need to use fertility drugs, you still have time. You still have your eggs are still good quality because we are born with our eggs. So for example, my eggs right now are, I'm going to reveal my age, but they're 42 years old. So my eggs are not too great right now. Whereas if I was 25, my eggs would be much better quality. So your egg quality depends on your age. So we don't want that to be an additional problem to having PCOS. So trying to get pregnant younger always helps. Obviously, sometimes that might not be the case because you may not have your Prince Charming yet, but it's always recommended, especially before 35. And after 35, you're more likely to have a baby as well with maybe Down syndrome or spina bifida because of the egg quality. So that's another reason why age is an important factor. We've covered tracking ovulation using ovulation tests, but you can also track your cervical mucus, which is your vaginal discharge. So anytime your discharge is white, as in the color white, whether it's white and sticky or white and creamy or white and milky, generally you won't get pregnant at this time. It is a normal discharge, but when we are ovulating, we normally see a very clear, slimy discharge. So you can hold the discharge in your hand and you can stretch it like this and it doesn't break. So that's the type of consistency we're looking for. So what I recommend is when my ladies start doing their ovulation tests on the day that I recommend them to, they also make a note of their cervical discharge, their fluid, so that we can have it documented and we can check the changes that are going on as well. Because a lot of ladies with PCOS and low progesterone, they may not see that cervical discharge. And even when they start to ovulate, they may not see it and they may not have the right environment in the vagina to keep the sperm alive. So that's an important factor. And if they don't, we do use supplements to increase that type of discharge that we need as well. Also, a way to improve fertility with PCOS naturally is taking multivitamins. So we have discussed metformin. Some people don't like to take metformin because, especially if it's taken with dairy products, it can cause diarrhea and upset tummy. So there is an alternative. It's called myo-inositol. This is what we use, and we use them within other PCOS vitamins. In combination with taking other things as well. So it has myo-inositol, which can help manage the blood sugar. It also helps aid with weight loss as well. It has omega-3, magnesium, zinc, and vitamin D. So all of these help with ovarian support to regulate your cycle and hormonal support. So we use these in terms of multivitamins, and I'm a herbalist, so I love herbs. So the herbs I use for PCOS are for progesterone. So women with PCOS have more of the male hormone. That's why they start to get the male facial hair pattern, the beard growing on their chin, which we don't want because we're women. So I use a herb that brings up your progesterone levels. Dr. John Barker talked about prolactin as well. When you have PCOS, sometimes the prolactin is elevated, and when your prolactin is elevated, that can sometimes bring down your progesterone as well. So we want to bring up the progesterone and bring down the prolactin and the male hormones. So we use my number one herb that we use is the Vitex fruit, also known as shasberry. Okay, normally use 400 milligrams twice a day. This one works well in regulating the woman's cycle. It's a herb which comes from the Mediterranean. It's used for centuries to support traditional monthly cycles. Okay, it's a fruit that's put into a capsule. You take it twice a day, and the side effects can be, well, there isn't many because it's herbal, so generally there isn't many side effects, but we do hear back that it can increase your sex drive because it is it's bringing up your progesterone levels, the female hormone. So sometimes when you have high androgens, the male hormone, which is prevalent in PCOS, your sex drive might be really low. You just may not feel for sex at all. So, and that's why it happens to make you feel for sex when you start taking progesterone, which is the female hormone. So we use this one, and we also use black cohosh as well, which is another herb that I use with my PCOS ladies. So in combination with diet changes, herbal medications, and supplements, these are ways that we can naturally improve fertility with PCOS, and then doing our tracking of our ovulation as well. So sometimes ladies that are overweight, for example, maybe they're not following the diet or they're not taking medication, they might need ovulation induction drugs such as Clomid or Letrozole. These are tablets that are taken normally from the second day of your period for 5 days, and they stimulate the ovaries to make you release eggs. Now, again, these drugs don't normally work if you don't make changes first. So for example, you can naturally bring up your progesterone levels with the Vitex. You can change your diet so you lose weight. Try to lose at least 5 to 10% in weight loss, can assist with ovulation naturally as well. And again, a BMI under 30 would be perfect. We don't normally recommend fertility drugs if you're over 250 pounds or if your BMI is over 30, because they don't work, and that reflects our success rates. So we'd like you to lose weight, bring up your progesterone levels, also manage stress. That's really important. So I think that was covered already, but I'll just cover it briefly. Stress increases your cortisol levels, and that can inhibit ovulation as well, and that can affect your menstrual cycle. So we don't want that to happen. We want you to be as relaxed as possible to get pregnant, because when your body realizes that you're stressed, you're overworked, or you're overwhelmed, your body may not naturally just get pregnant. It's like nature's way of saying she's not ready yet. So it's very important that you are, walking, doing some nice relaxing exercise, maybe some yoga, eating healthy, taking care of your body so that your body can grow a baby. Okay. So we've covered what to eat, what not to eat, tracking ovulation. Just to recap, diet and exercise, I've been through this. Thank you, April, for doing my quick slideshow because my laptop wasn't working this morning. Yeah, so basically this is most of the things we do here. I also do traditional medicine as well. So I practice traditional Chinese medicine, which is acupressure. So acupuncture is using needles, and acupressure is very similar to reflexology. It's points on your feet and your ankles. It stimulates your metabolism. It helps with weight loss. It helps to relax my patients. My patients that have sleep apnea, for example, it helps them to sleep better at night. And all these things contribute to improving fertility with PCOS. So I offer a comprehensive holistic appointment, which mostly includes herbs, stress management, ovulation screening, and acupressure as well. So if you have any questions, or if you would like to be added to my Healthy Eating PCOS group, feel free to message me your number. I can add you. Yeah, so if you have any questions, feel free to put them in the group chat, and I'll happy to be answering them for you.
Thank you, Charlotte. This was so informative, and for women who are trying to get pregnant, who want to have children but suffer from PCOS, this was such an informative presentation, especially, you mentioned alternatives to some of the medicine that might not be working, that, a lot of women who suffer from PCOS might be using, but they're not seeing changes. One of the common things across the last three presentations that we've had is that diet and exercise is very, very important. I personally was very disappointed to hear that bakes should be removed from the diet. Anything that has flour in it. For those of us who like our bakes and we like our dumplings, that is a stab to the heart, but it's necessary because we need to, try to remove as many processed and refined foods in our diets as possible and focus more on fresh fruit, fresh vegetables, things that will help us manage, PCOS as much as possible. So thank you so much. And if you do have any questions, please pose them in the chat. Somebody asked, Kira asked, sorry, what do you give your patients for sleep apnea? If you mentioned it, I may have missed it.
So there's two things that I do for sleep apnea. I do therapy, talk therapy. I do acupressure, which is a form of traditional Chinese medicine. It's very relaxing. It's points on your feet and your ankles that we stimulate. And I also use the herbal foot detox pads as well. So they sleep with them underneath their feet at nighttime. And it has antifungal and antibacterial herbs within the patches, and they smell really nice, and they just promote relaxation. So they work really well to help you sleep better.
All right, great. And that's a great segue into our final presentation, which will be made by Dr. Azizi Popo-Hippolyte. And she will be talking about how PCOS impacts sleep. So, Azizi, you have the floor.
Okay, good afternoon, everyone. I am Dr. Azizi Popo-Hippolyte, and it's a pleasure for me today to speak to you about the link between PCOS and sleep. Okay. Okay, great. So we have Polycystic Ovarian Syndrome and sleep disorders. So in our short presentation today, we're going to speak about how hormonal imbalances can affect or disrupt our sleep cycles, We're going to talk about some common sleep disorders that are associated with PCOS. We're going to talk about how poor sleep quality can worsen previously existing PCOS symptoms, as well as look at some of the long-term risks of the sleep disorders associated. So before we can talk about the link between hormones and sleep, we need to establish a few things. For example, what is our circadian rhythm? So we're going to talk about our body's natural 24-hour cycle. It's not governed by the time on our watches or our phones. It's your body's inbuilt clock. And this clock regulates not just our sleep patterns, our hormone secretions, our behavioral changes. And when we speak about a sleep cycle, many of us have heard or have experienced the feeling that we forgot to put our alarms on in the morning, but we somehow wake up the same time we were supposed to. That's really our natural clock going into effect. And our circadian rhythm one second. Right, our circadian rhythm is controlled by and regulated by different hormones. There are multiple, but for the purpose of understanding in a more simple form, we're going to talk about a few, mainly melatonin, cortisol, insulin, and our androgens, including testosterone. We have firstly melatonin. This is known as our sleep hormone. It promotes sleep and relaxation. And the way it works is that as our day comes to an end, as we near the evening, we normally see an increase in melatonin, which induces sleepiness. It promotes sleep. And generally it responds to a decrease in light outside. So as it gets dark, our body normally increases on our melatonin secretion, promoting sleep. Then we have cortisol, which would be on the other side. Cortisol is known as our stress hormone. It creates hyperalertness or wakefulness. So in a normal sleep cycle, we have melatonin starting to increase in the evening, peaking at night where we're able to maintain sleep. And as we near the morning and light comes up again, we have peak in cortisol, which causes us to awaken. But what happens in PCOS, persons who suffer from PCOS tend to have higher evening cortisol levels. And if you remember what I mentioned, cortisol being the hyperalertness, the wakefulness hormone, you would imagine that if this hormone is higher towards the evening or the night, melatonin will not be able to invoke the sleep and the peace that we're looking for. So we see that in PCOS, due to higher cortisol levels, we have reduced sleep quality as well as sleep efficiency seen in persons who suffer from Polycystic Ovary Syndrome, as well as we have insulin. With insulin, it is that it promotes the insulin resistance, With insulin resistance, that means our bodies aren't functioning or aren't receptive to insulin in blood, causing fluctuations in our blood sugars. This unstable blood sugar can trigger awakenings during night. So it may be that, yes, we fall asleep, but we don't stay asleep. And one of the causes could be due to insulin resistance, causing our uncontrolled blood sugar fluctuations. Not only that, insulin resistance is also linked to weight gain and obstructive sleep apnea. And later on, we will see how weight gain and obstructive sleep apnea affect persons suffering with PCOS. And lastly, we have our androgens, for example, testosterone. Elevated levels of testosterone increase the risk of obstructive sleep apnea, which is one of the more common sleep disorders that persons with PCOS suffer from. Okay, so let's talk about obstructive sleep apnea. Persons who suffer from obstructive sleep apnea normally experience various symptoms, but what is it? It is when repeatedly we have stopping and starting of breathing while in sleep. You're not the one controlling it. It's more of an automatic response. So you may be sleeping and a family member alerts you, wait, you stopped breathing. And you're confused because you weren't aware of it. And that's one of the many signs that one can use to pick up, hey, I might be suffering from sleep apnea. My breathing patterns, my breathing is stopping while I sleep. And not just the witness pausing of breathing during sleep, but we have loud snoring, gasping or choking during sleep, and as well as the excessive daytime sleepiness. So we must note that PCOS does not directly cause obstructive sleep disorder, but it significantly increases the risks. We also have insomnia. So many persons speak about, I suffer from insomnia, but what really is it? It is the inability to initiate or maintain sleep. This also includes periods of wakefulness during the night. And it is linked to not only increased androgens, which is typically seen in PCOS, it is also linked to low melatonin and increased cortisol, as well as low progesterone. Then we have daytime sleepiness, which I like to look at as a consequence of other sleeping disorders, although it in itself is classified as a sleep disorder. And if you look at cause and effect, imagine that you can't fall asleep, you can't stay asleep, your breathing stops, so your sleep is not optimized. What would that lead to? During the day, you're going to be tired. You're going to feel the fatigue. You're going to feel drained. And this daytime sleepiness is not just linked with lack of proper sleep, but it is also a consequence of insulin resistance, obesity, and hormonal imbalances linked with PCOS.
Azizi, before you move on, I just want to make sure that everyone can see your screen because I'm only seeing the first one. So just making sure that everybody else can see in the chat.
Let's see.
Okay, they're saying yes.
Okay, great.
Okay.
So we were speaking about the sleep disorders, and we mentioned that obstructive sleep apnea, as well as insomnia, daytime sleepiness are some of the more common sleep affections that persons suffering with PCOS would experience. So when we think about what are the consequences of poor sleep quality or not being able to sleep on my health, aside from the obvious, I am tired, I am fatigued. So we can see the effect of poor sleep on some of the more frequent PCOS symptoms like weight gain or mood disorders, as well as insulin resistance. So in the case of weight gain, so obstructive sleep apnea, which we spoke about, would be the repeated stopping and starting of breathing during sleep, not only lead to fatigue and hormonal imbalances of our hunger hormones. So our hunger hormones, we have leptin, which is going to give us the sense of fullness, and we have ghrelin, which is going to be the one initiating hunger. So poor sleep due to obstructive sleep apnea cause these hormones to go in disarray. So we're going to have ghrelin doing more of what it's supposed to do, being secreted more, and this is going to increase our appetite. Increased appetite, we eat more. Eating more, eating in excess, we have weight gain. Not only this, but poor sleep can also further elevate already elevated cortisol levels. And cortisol as well can increase appetite. We start stress eating, we just have uncontrolled hunger. But not only that, it contributes to visceral fat storage. And when we think about visceral fat storage, we're thinking about the fat around our organs, our central fat. We have stomach, back in this area. And this is one of the more dangerous places for your body to store fats. It increases your risk of cardiovascular diseases, for hypertension, stroke. So we could see how cortisol also is playing a role there. We also have poor sleep affecting mood disorders that persons suffering from PCOS are already privy to. So not only is it going to drain your energy levels, you're going to start experiencing deficiencies in cognition, brain fog, having problems focusing during the day, irritability, and we have insulin resistance. Now, many times we speak about PCOS, we think insulin resistance. That's why, for example, previous panelists spoke about persons using metformin in the treatment of PCOS. It's also used as a drug in the treatment of and control of diabetes, because insulin resistance leads to diabetes. And taking drugs that reduce your insulin resistance or reduce or increase your capability of utilizing blood sugar can help. So in the case of obstructive sleep apnea, so if you're having repeated pausing and starting of your sleep, what's going to happen? Your brain is going to not get the amount of oxygen it needs. Now, less oxygen, what is it going to lead to? It's going to lead to not just sleep fragmentation, but something we call oxidative stress, which lead to increase in inflammation and inflammatory cues in our body. And being in a state of increased inflammation, what does it do? It decreases insulin sensitivity. So if we speak about insulin resistance being our body is not able to utilize insulin in blood to effectively lower our blood sugars, you can imagine how sleep apnea, low oxygen levels, causing the body to be less sensitive, can impact in blood sugar levels, not only through that pathway, but the increased cortisol associated with obstructive sleep apnea causes what we call lipolysis, which is a breakdown of fatty acids. Now, these fatty acids in blood, they also can decrease insulin sensitivity. So no matter which pathway you look, you could see how, whether it be through the lack of sleep, we see it all boils down to the end, decreased insulin sensitivity or impaired glucose metabolism, which at the end leads to the developing of diabetes.
Okay, so just a quick stop. Some people are saying that they're only seeing your first slide. So just verifying that you making sure you're sharing your screen and that it's moving as you move along the presentation.
Yeah, it is moving with me. I'm not sure why other persons aren't seeing it. Okay, let me try sharing the screen from scratch.
Okay. Okay. Okay, someone says it shows that you have paused screen sharing. Okay.
Okay, so I have started back the screen sharing. Can everyone see the slide that I'm on now? It says poor sleep and long-term risks of health.
No, we're still seeing the first one.
Okay.
Somebody said, yes, I
Excuse
can
me.
now.
Do you all mind if I share?
Yes,
Let's see if
please.
it helps. Okay. Okay, audience, just give us 2 minutes or less. Okay, can you see my screen?
Yeah, we can.
Yeah.
Okay. Right, I'm going to mute myself. You let me know if the slides are changing. So which slide should I go to, or should I start from the
You
beginning?
should go all the way to the bottom where we have the long-term effects of the sleep disorders. Poor
Okay,
sleep
no
and
problem.
long-term risk of health. The second one.
Okay, no problem.
Thank you.
Okay, and April
Okay.
just, right, great.
Can everyone see now?
Yes.
Okay, so we're moving to the second slide. Poor sleep and long-term risks of health. Sorry about the technical difficulties on my end. I'm not sure why. Thank you so much for your patience. Can you switch to the next slide, please? Okay, so we are going to continue speaking about poor sleep and the long-term risk on health. So we see that obstructive sleep apnea as well as poor sleep are not only linked to the worsening of symptoms of PCOS, like your mood disorders, your insulin resistance, as well as your weight gain. We also see it being linked to hypertension, ischemic heart disease, stroke, metabolic disorders, like we mentioned, insulin disorder, insulin resistance, type 2 diabetes, as well as dyslipidemia, which would be uncontrolled or problems related to fat in your body. So when we speak about cardiovascular disease, it says that sleep disorders are linked to higher risk of cardiovascular disease through different mechanisms that include increasing blood pressure, elevated stress hormones, as well as heightened inflammation. So when we have a lack of sleep, like we said, we have increased production of cortisol, which would be our stress hormone. And not only would we have increase in cortisol, we also have increase in adrenaline. And these two work together, constricting our blood vessels. So if we have a smaller blood vessel, we have the same amount of blood needing to pass through this constricted blood vessel, which means our heart is going to have to pump harder to get that same amount of blood through a smaller space. So we have the developing of high blood pressure. And not only is it in this form we see the developing of high blood pressure, but naturally in our sleep, our blood pressure dips. So if we have firing of cortisol during our sleep hours, our hearts and blood vessels don't get the necessary rest where it would get from that dip in blood pressure during the night. So we also see that our body is going to stay in this constant state of hyper-alertness, this constant state of fight and flight. So we're going to have constant increases in blood pressure. Not only this, we also can see the link with long-term effects on post-sleep in the developing of type 2 diabetes, extremely linked with the insulin resistant myself and other presenters have mentioned. So it says that sleep quantity and quality affects the patient's capacity to control their metabolism in type 2 diabetes. Poor sleep reduces insulin sensitivity. So when we think about how does it really work, how would the type 2 diabetes develop? This is naturally by the consequences of having polycystic ovarian syndrome. We see it because of an increase in weight gain. We see it because of sleep disorders impairing our body's responses to glucose uptake. We have the developing of type 2 diabetes. So this given, can you switch to the next slide, please? So given all the information that we've had, that how our hormones affect sleep, how lack of sleep further causes our hormones to go in a disarray, what can we do to better our sleep? So there are just 6 key things that we're going to speak about. We're going to first speak about maintaining routine. Having a consistent sleep schedule can help you pick up on sleeping cues. For example, you go to bed the same time every day, you wake up the same time every day, whether it be a weekend or a weekday, whether you have to wake up for work or not. Your body is smart, but your body can be tricked. So sticking to a schedule gets your body into the habit. At this time, I'm going to get sleepy. I'm going to produce the necessary hormones. I'm going to get sleepy. And this time I'm going to wake up irrespective of whether I wake myself up or I have an alarm. Then we have, don't be afraid of the dark. So many persons and science has proven that sleeping in cooler, darker areas can promote sleep. And if you backtrack to when I spoke about melatonin secretions increasing as light decreases in the day and darkness comes, you can see where that can play in. How dark and cool places can help not just initiate sleep, but maintain it. Then we have food. Not necessarily what we eat, although it is extremely important, the when we eat. We should avoid eating heavy meals closer to bedtime. Energy is required to break down food. Energy is required for digestion. So if your body is going to be working hard to digest the food that you just put in, it's going to be less focused on putting you to sleep and giving you that well-deserved rest. Then we need to wind down. For some, it may not be as easy as, let me jump in bed, let me close my eyes, and I will fall asleep. Preparation in the bed may be necessary. You wind down, whether it be stretching, whether it be meditating, whatever works for you. But winding down doesn't mean sitting on your phone, scrolling through, doom scrolling. And that's what many of us do. We lie in bed on our phones, doom scrolling before bed. But the reality is the light of the phone, especially if you don't have your blue light filters, is going to induce the presence of light. It's not going to give your body the perception it's time to wind down, it's getting dark. So it's going to give daytime cues. So what's going to happen? Melatonin secretion won't be the same. You're going to have increased cortisol. So we need to find ways to wind down, phones down, and just stay active throughout the day. It has been proven that staying active during the day, physical activity, exercise, walking, it does improve the quality of sleep at night. And one we must always remember as well, like Miss Charlotte Bryan spoke about, there are other methods to help sleep. For example, she mentioned about the acupressure, stimulating your different acupunctural points that can also help improve sleep and achieve relaxation. And lastly, we must remember that when it comes to sleep, one cap does not fit all. What may work for you, what may work for your fellow friend who does does experience sleep disorders associated with PCOS may not work for you. So you explore, give everything a chance, and if it works, you stick with it. Next slide, please. So I just want to say thank you so much for listening. I hope that I was able to help someone learn a little more about PCOS and sleep. And thank you so much for your patience with my technical difficulties. Thank you very much.
Thank you, Dr. Popo Hippolyte. This was very informative. We really got the full download on how sleep and PCOS are interlinked and the importance of having sleep hygiene. Everything that Dr. Hippolyte highlighted was important, but it's also important, like she mentioned, to have a sleep hygiene that is beneficial to your body so that you can see the results in terms of how PCOS adversely impacts you. And that is reduced. So being able to maintain your routine, putting your phone down after a certain time, because all of us spend so much time on social media, or we're using our phones to, I don't know, run a business, or we're using our phones to do other things. And we spend all of our daytime on our phones to the point where some of us even use it to fall asleep. So finding alternatives to fall asleep, like winding down, stretching, meditating, prayer, if that's something that you do, and being able to, once again, eat properly. When you eat is important. So reducing larger meals closer to bed. All of these things will help with having a proper sleep routine. There's a hand up? April?
Yes. Yes, that would be me. I just have a quick question. I know of someone who lives overseas and they actually had a sleep study done in order for them to be diagnosed with sleep apnea or any other issues that they may have with sleep, not only for Dr. Zizi Coco, but for anyone on the panel. Does anyone know if that is an option in the Caribbean, St. Lucia, or any other?
Yeah, so if any of our panelists are aware of any options within the Caribbean to have that done, please let us know. And now we'll move to our question and answer. And please, panelists, if you do have that information, you could just, unmute and let us know. Charlotte?
I think Tapion Hospital might have a department that does something to do with your sleep where they monitor you. They have machines. I'm sure I've seen that at Tapion Hospital before.
Okay, great. So Tapio, to answer your question, April is an option, possibly an option. Okay, so we had a few questions over the course of our presentations. One of them, I think, came during the time, Dr. Barker, you were presenting. So just to go back to that. And the question was, what is the recommendation to help manage low progesterone which causes, breakthrough bleeding?
Right. If you get in normal periods, which is every 21, 28, maybe a bit regular or irregular, but if you get in breakthrough bleeding in between your periods, then what I would suggest, depending on your age, you have to get evaluated thoroughly, because it can be hormonal or it could be due to what we call intrauterine pathology, which could be like an endometrial polyp or a fibroid. So if we put you on the pill, then that would sort out the bleeding in between the periods. If it's due to an infectious cause, then usually, because if you're on a pill and you start having breakthrough bleeding, one of the causes is infection. However, sometimes the pill could be of a lower dose, so then you might have to increase that as well. So it's not just one thing we gotta look at. So we gotta look at if you're on medication before, if you was on the pill, and if so, if you was on a low dose of the pill, we then got increase the dosage. And then the next cause would be infection and or if you have actually physical pathology inside the womb.
Okay, thank you. There was another question from Sina. I believe she asked, can Ozempic be recommended for weight management?
That's a question you have to talk to your GPs about because we as gynecologists, we don't actually prescribe Ozempic. So I would advise you to speak to another medical personnel. I can't help you on that one because I don't prescribe it. And I am not, it is a drug that I don't use.
Okay. We had another question from Yasmin. She said, I've had issues gaining weight my whole life. I have PCOS and adenomyosis. Is it safe to even attempt to gain weight with PCOS and adenomyosis?
If you gain weight, the PCOS will get worse. In terms of the adenomyosis, the adenomyosis is essentially when you have cells that you line in the womb inside the uterine muscle. So every time you get a period, you get bleeding in the muscle, and this is extremely painful. So the only way to treat it is with hormones. Um, so then you will have to be put on the pill. This will give you short-term relief, so you can either do it every month or what we call tricycling, whereby you take the pill for 3 months and then the fourth month you let your period come. In relation to the gaining of the weight, if you gain weight, then more than likely your symptoms for PCOS would increase.
Okay, great. I did have a question as well for, any of the panelists. Oftentimes, and most of you, if not all of you, highlighted the importance of diet and exercise. When it comes to exercise, there are so many different things that can be done to be active, right? A lot of the things that people focus on when they're exercising is strength training, which is weightlifting or trying to build on their muscle mass. But I wonder, with strength training and then you have more low impact training, like for instance, people do Pilates or they might do resistance training. Some people do like body weight training. What is a better option for women who have reproductive diseases like PCOS? Because strength training might cause or have a lot more like impact on the body because it's so like intense. So as professionals, what would be like the best type of training for women when it comes to exercise that might reduce the pressure, the impact on the body, and help with some of the PCOS related conditions that they might have?
I usually advocate any type of exercise, be it walking, running. Weightlifting is better in relation to increasing muscle mass, and then what it does is lower your blood sugars and stuff. So the actual resistance training would be the best, but everybody's different. I mean, if somebody can lose 20, 30 pounds on walking, then and that's what they like, then I tell them do that. If they like rowing, they can do that, or if they like cycling. So I'm not specific as to which type of exercise they do, as long as it's active.
Okay, thank you. We have another question here from Verity, and she asks, is it okay to do intermittent fasting with PCOS?
Usually fasting has been shown to improve your glycemic control, and then essentially what it does is to let the body break down fat and ketones, use it as fuel. So it actually is pretty good for your fasting blood sugars. So I don't have any issue with intermittent fasting.
Okay, so yes, Verity, it's a good option. Do we have any more questions? Okay. If we don't have any more questions, then I am going to hand over to April to give closing remarks.
I'll be reading from my computer. Because I don't have direct eye contact. Can you see me? Can you hear me?
Yes, we can.
So good afternoon, everyone. My name is April Louis. I am the Vice President of Iyanola Wombmanhood, and it is truly my honor to deliver today's vote of thanks as well as the closing remarks. On behalf of Iyanola Wombmanhood, our executive members, volunteers, and supporters, I extend our deepest gratitude to our distinguished panelists for dedicating their time and expertise to this important conversation. Your presentations have provided women in St. Lucia, across the Caribbean, and within the diaspora with specialist knowledge that is often difficult to access. We are sincerely grateful to Ms. Brenda Roach, counseling psychologist, mental health advocate, and longtime supporter of Iyanola Wombmanhood, Dr. John Barker, consultant OBGYN and medical director of JRB Medical Center, Ms. Charlotte Byrne, holistic family practitioner, clinical director of the Natural Fertility Center, and another valued long-term supporter of this organization. Dr. Zizi Kesia Popo Hippolyte, general medical practitioner. Your insights today were impactful, informative, and empowering. For many women living with PCOS, access to this level of expertise is rare, and your contribution has made a real difference. We wish each of you continued success in your professional journeys. To our audience, thank you for taking the time to be here, to learn, and to engage. Your commitment to becoming more knowledgeable about PCOS helps break the silence around a condition that too often goes unrecognized despite its serious implications for our health, our families, and our nation's social and economic development. Special thanks are also due to our planning team, whose hard work made today possible, and to Ms. Beverly Ann Hippolyte, who graciously hosted and emceed this webinar. Finally, I remind you that we will close PCOS Awareness Month with our Wear Teal for PCOS initiative. We invite you to submit your photos wearing teal or light blue, which will be shared on the last day of this month. And lastly, as part of our closing remarks, I would like to give a gentle reminder. Women living with PCOS, such as myself, are integral to every part of society. We are teachers, doctors, secretaries, fisherwomen, agriculturists, mothers, wives, sisters, and breadwinners. When our health suffers, when the health of women suffer, the ripple effect is felt by entire communities. As a society, we must move beyond just objectifying women's bodies and begin truly investing in their wealth and health wellness. Once again, thank you to our panelists, our hosts, our organizers, and to you, our audience. Your support ensures that women's health remains a priority. We ask that you do one more thing for us, that you like and follow our social media platforms, all which carry our name on YouTube, Facebook, Instagram, LinkedIn, and our WhatsApp channel. We promise you that there will be many more informative sessions like these. Thank you so much, and do have a wonderful evening and a productive week. Thank you, everyone.
Thank you, April. Thank you for these closing remarks. Thank you to everyone who tuned in today, to our panelists for giving such informed and detailed presentations. everyone who asked questions, everyone, you've been with us since 2 p.m. So we appreciate you spending your Sunday evening, afternoon with us. And we thank you for being part of this community. As April highlighted, please follow us on all social media. We're also on LinkedIn, so Facebook, LinkedIn, Instagram. Join our WhatsApp channel where we have daily information about, the reproductive diseases that we're trying to raise awareness on. And thank you so much. Thank you to everyone who joined. Thank you for participating. We really appreciate your presence here this afternoon. And please do take care of yourself.